Good morning. I would like to go over how the NCC Psychiatry Residency program evaluates its trainees, and it's meant to help you understand how we determine how a trainee should progress throughout their 4 years of training program. Our objectives are to review the evaluation process as well as understand the role of the ACGME milestones in this process, and then finally understand the role of a clinical competency committee, what the role is and what the makeup of the clinical competency committee is. So this is the overall evaluation process. There is input that we get, and this is all essentially raw data, and then we ask the clinical competency committee to make their assessment of that information. So as the information flows in, the clinical competency committee has to make sense of it and has to ascertain how an individual trainee is progressing, and then the output from the clinical competency committee is the determination of an individual trainee's milestones, as well as any other additional feedback they are going to receive. So what are some of the inputs that we use in the program? So obviously I will discuss what clinical competency committee is, but it is essentially a bunch of your faculty members appointed by the program director. And so during discussing each and individual trainee, their personal observations are utilized as part of this input, and they discuss their observations, especially any behavioral observations, in order to come to some conclusion about various milestones. We obviously use the written evaluations. So if you are a trainee, we really want you to stay on top of your written evaluations. If you have done 6 rotations and we only have 3 evaluations, we are blind to the other 3 evaluations, and essentially we're gonna miss out on potentially things that would move you up on milestones. So it is your professional responsibility to make sure that you, one, assign evaluations when you're asked to do so, and then to follow up and keep your faculty accountable to getting you these evaluations. The third area of input that we use to evaluate our trainees is what's in their MedHub CV and their portfolio data, which is also in MedHub. And so we have a very finite amount of time where you have to discuss many trainees. So the only source that we use as your CV is your official CV, and you may have another standalone CV, but the only thing we look at is what's inside MedHub. And the things that we care the most about are what sort of research you've done for the time period that we're evaluating you on, what teaching, presentations, papers you've published, what leadership roles, so make sure that you keep those in there. So if you are part of a leadership position in the program, we want to know. If you are part of a committee member in the hospital, outside the hospital, we want to know that. If you are participating in some other extracurricular activity, we want to know that, as well as your QIPI projects that you're involved in. And then finally, we also receive input on professionalism behavior from program coordinators, because they have to deal with the trainee the most, And so we want to know if they have difficulty getting productive responses from a given trainee, i.e. someone who is not entering their duty hours or not responding to required paperwork, etc., which may portend unprofessional behavior. And so all of this information is then taken by the Clinical Competency Committee, and they try to make sense of it. So there's sort of the overarching global interpretation of it, and what a Clinical Competency Committee is it's essentially a committee of your faculty members, and this is an ACG meet required committee, and the goal here is to take the wisdom of the group and the faculty who know you the most, and for them to discuss you and essentially provide input to the program director on how you're progressing as the trainee. It has to be a minimum of 3 board certified psychiatrists, and one of the benefit of this is that it avoids any halo effects, which are if, let's say, a trainee is struggling and there's a risk of them ending up in a certain frame or a certain box where everybody is perceiving them negatively, and so we try to avoid the halo effect. And then there's also something called the reverse halo effect, which is a particular trainee may be put on a pedestal, which may blind the CCC to recognizing areas of improvement. So the goal there is to have a fair and judicious process to evaluate the data in an objective and fair manner. And this is one of the reasons why clinical competency committees exist, rather than just leaving it up to a single individual such as the program director to make all these tough decisions. So these faculty members have to be appointed by the program director, and so we invite the faculty who actually work with that given group of trainees. So in our program, we have 4 different clinical competency committee, and to make things easy, we have divided it by PGY level. So for example, PGY 1 has its own, and then each of this clinical competency committee has to be chaired by one of the faculty. So in our case, we have 3 associate program directors. Each of them also are chair of one of these clinical competency committees, and then we have a 4th core faculty that chairs one of the 4th clinical competency committee. These clinical competency committee use something called the ACGME Milestones, and I'm going to show you those in a moment, in order to score every single individual trainee. So for example, if we're doing the PGY1 group, there are potentially 14 trainees that we have to go through, and it takes several hours to do this. At minimum, this trainee needs to receive a written evaluation, a summative written evaluation once a year, but we do it twice a year because we think that more frequent feedback is going to help you progress in a productive manner. The other thing with clinical competency committee is if there's an acute situation with a particular trainee, the program director can request the CCC chair to hold an ad hoc meeting to discuss a particular situation that has to do with a trainee's progression. So, as I mentioned before, the Clinical Competency Committee looks at the ACGME milestones to determine where an individual trainee stands. They also determine whether or not the individual trainee is progressing normally. And in rare occasion, they may also discuss, based on all the input, if a given trainee is at risk. Now, at-risk trainees, we typically spend more time on those individuals just to make sure they're getting a fair shake. And so the Clinical Competency Committee and subsequently the chair may recommend to the program director whether an individual may need some additional help. So robust feedback, maybe some informal mentorship, maybe they need some additional resources. So that's often the case. Given the severity of the situation, if someone is having significant difficulties and are struggling, then that trainee may either be recommended for in-program remediation, or if it's something more serious, may be recommended to be referred to the NCC academic subcommittee. And so the difference between the two is the in-program remediation is exactly what it says. It's overseen by the program director, and that given clinical competency committee chair is responsible for ensuring that the trainee receives the required remediation, resources, other things. And resources may include organizational skills, or it may include some assistance with health resources, etc. But the in-program remediation does not end up on one's permanent record, so you do not need to report that when you graduate to state licensure or to credentialing committee when you're applying for credentials at your next duty station. The referral to NCC academic subcommittee is more serious in that this is something that does end up on your permanent record and has to be reported. And then with the NCC academic subcommittee, usually people remediate and they are taking off of it, but people who fail to remediate at the academic subcommittee may be recommended for termination from the program. As far as the in-program remediation goes, most people often remediate and they go back and they progress and they graduate. A minority might end up still struggle despite being on in-program remediation for 3 months, 6 months, and the clinical competency committee, when they meet again to reassess, may recommend to the program director that that individual is referred to the NCC academic subcommittee. Now, the clinical competency committee's chair can only give recommendations, so these are non-binding essentially, and the program director may choose to take that recommendation and execute it the way it is, or they may change it, or may essentially ignore the recommendation. And the other, so besides the trainee receiving their milestones and feedback on how they're progressing and any subsequent actions from that, they also receive a narrative feedback, and so it's in written, and this happens twice a year. So you as the trainee will receive a mid-year assessment and written feedback that you will sign, stating that you have received that feedback, as well as your milestones at that particular time, and then there's end of year feedback. And so typically the CCCs meet in December timeframe, and then in late April, early May timeframe. So one other thing you could do to help the process is to make sure that you maintain your MedHub portfolio in the CV. as well as ensuring that you are keeping track of your evaluations from your training sites. And I recommend that you send, if you're spending 2 months at a given training site, try to get every 30 days, try to get them to do an evaluations on you, because people just don't really remember things that happened 2 months ago. Now, those that are on outpatient experience, at minimum, you must have an evaluation done every 3 months. So you'll get a total of 4 evaluations during your outpatient year. And then finally, technically, if you do not have a written evaluation, I have the freedom as the program director to not accept that, because I can technically say I have no idea whether you passed or failed this rotation. So you must make sure that you have written evaluations done on you. And obviously bring that up the chain if a particular faculty is ignoring your request to do that evaluation on you. Okay, so a little bit about milestones before we end this video. The Psychiatry Milestones version 1 has been around since 2015, and the new version is going to go live summer of 2021. There are 22 milestones that cover the 6 ACGME core competencies. Here's the link. You can then click on the milestones icon to access the latest version, but I'm going to go over that with you in a second. So the milestones are intended, just like when you're doing pediatric rotation, the children can meet certain milestones. Often you're expected to progress and progressively get better on those. In rare cases, residents may regress on a given milestone, and often those tend to be professionalism type of milestones. So let me show you what those look like. So this is the version 1 of Milestones. As you see, this is from July 2015. And it takes a lot of efforts to come up with these. And I recommend that you access these and you look through them, just to get a sense of what your end destination is and what you're trying to achieve. There are 5 levels to these. Level 1 is someone who's an incoming trainee, so essentially an intern. Level 2 is advancing, and then the higher you go, the better it is, essentially. And level 5 is sort of reaching that ultimate mastery of that given competency. And so these milestones have a competency domain, which here is PBLI, and this is milestone number 3. So competency has to do with practice-based learning and improvement here. PBLI, MK would be medical knowledge, for example, and those are one of the 6 ACGME core competencies. Then there's a subcompetency, i.e. teaching here. And then what are the threads under this subcompetency? So development as a teacher and observable teaching skills. And then here, level 1, you recognizes the role of physician as a teacher. So this is sort of an attitude, essentially, right? So most trainees would be at this level, even as a senior medical student role you probably have been teaching. And then as you go up, here are some of these behavioral anchors. And so in order for a trainee to get a 2, or a level 2 milestone, they have to check all these boxes. If you check some but not all of the boxes, or even one of these boxes, one of these anchors in level 2, but not all of them, then you'll be at 1.5. And similarly, you can be 3.5 if you check either 3.1 or 3.2. But if you check both 3.1 and 3.2 based on the determination of your CCC, your clinical competency committee, and how when they discuss you, if they think you've checked all of these, then you're going to be level 3. And the deal is we want you to continue to progress. And so it starts off with your milestone 1, and PC is patient care. And so patient care 1, patient care 2, patient care 3, and then there's patient care 4, which focuses on psychotherapy, for example. And so these are the things that the CCC is challenged to opine on, whether or not you're able to do it. So again, it is very, very important that we have the right input in order to make the right determination. If you're missing evaluations, then you're not going to end up reaching that higher milestone on the assessment that you could have. Okay, so here's PC5, and then we go into medical knowledge 1, and so some of these we assess by looking at your PRITE scores, for example. That is part of our input that I should have mentioned early on. And so you go into medical knowledge, and then we've done patient care, medical knowledge. Next one is SBP. And PBLI, practice-based learning and improvement. So that was PBLI 3 that I showed you earlier. Then professionalism. By the way, SBP, system-based practice. So things like QIPI projects fall under, in some ways, under PBLI, and in some instances may fall under SBP. And then interpersonal communication. So these are the milestones. There's 22 of them. And this, for example, deals with your ability to share information and keep records, doing notes, for example. And so I highly recommend that you look at these and allow it to kind of give you a sense of where you need to go in order to get to that walking the stage on your graduation day. So with that, please feel free to contact your CCC chair or the program director if you have any questions about how you're evaluated. Thank you.